Welcome to today's Impact Week webinar on rural health problems with solutions. I'm Dr. David Harder, University Professor of Medicine and Director of UMaine Institute of Medicine. Our President, Dr. Joan Ferrini-Mundy, will begin opening remarks. Joan, thank you. Joan, thank you.
Good afternoon, everybody. Can you hear me?
Yes.
Yes, good. Thank you. Welcome, everyone. I am Joan Ferrini-Mundy. I'm the president of the University of Maine and our regional campus, the University of Maine at Machias, as well as University of Maine System Vice Chancellor for Research and Innovation. And I'm so very pleased to be here with you to open up this discussion on rural health. I'll begin with our University of Maine land acknowledgement. The University of Maine recognizes that it is located on Marsh Island in the homeland of the Penobscot Nation, where issues of water and territorial rights and encroachment upon sacred sites are ongoing. Penobscot homeland is connected to the other Wabanaki tribal nations, the Passamaquoddy, Maliseet, and Micmac, through kinship, alliances, and diplomacy. The university also recognizes that the Penobscot Nation and the other Wabanaki tribal nations are distinct, sovereign, legal, and political entities with their own powers of self-governance and self-determination. Maine is the most rural state in the nation, according to the most recently available data, with about 61% of our population being rural. As a result, our communities face unique challenges. UMaine, along with the other University of Maine system campuses, works with those communities to address the challenges by fostering learner success, discovering and innovating, and growing and advancing partnerships. The University of Maine system is the largest producer of the state's professional healthcare workforce, and the majority of that preparation is led by UMaine. We educate the rural health workforce through academics and hands-on experiential learning in our classrooms, laboratories, and research centers and institutes. The UMaine system has 37 degrees and certificate programs in many health-related disciplines, including nursing, education, social sciences, food sciences, veterinary sciences, and counseling. Our graduates, including the more than 570 who graduated from those programs in 2020 and 2021, are embedded in our state's healthcare, educational, and counseling institutions. As we all know, the COVID-19 pandemic is having and has had and is still having an enormous impact on our rural communities and has heightened problems in rural healthcare. UMaine rose to meet those needs in the state in critical ways, from leading the design of new telehealth options to mobilizing testing and vaccination in the state, and continuing to prepare more nurses and other healthcare workers for frontline work and to wastewater testing, all the while continuing to make breakthroughs in basic research in our understanding of human disease. These efforts and many others continue to help address the state's needs and enhance the quality of life in Maine's rural communities. To seek innovative solutions for many of the problems facing rural communities, UMaine's Institute of Medicine is partnering with research groups and scientists, including those here at the university in the School of Nursing, the School of Social Work, the Center on Aging, and the Center for Community Inclusion and Disability Studies, and so many state and regional partners beyond the university. We are working together to address pertinent questions facing rural populations, including aging, substance abuse, healthcare delivery, and workforce development. In this Maine Impact Week webinar, at the beginning of our wonderful, fully planned week of great events and activities, rural health research, problems with solutions, we have a gathering of healthcare professionals, educators, scientists, and counselors from across the state, and they're here to discuss rural health and how, in partnership with healthcare institutions, the University of Maine can positively impact rural communities. Please now welcome back Dr. David Harder, who is Director of the Institute of Medicine, and he will introduce our moderator, Dr. Kelly Strout. It's great to be with you.
Thank you so much, John. So this webinar focuses on how work between the University of Maine, the University of Maine system campuses, and regional healthcare institutions enhance the quality of life for citizens in Maine. Dr. Kelly Strout, Interim Associate Dean for Health Sciences, Associate Professor and Director of the School for Nursing, will moderate today's discussion with physicians, faculty, healthcare professionals, and scientists on problems facing Maine's rural communities and ways to solve them. Dr. Strout, you have the podium.
Thank you. First, I'll begin by introducing our expert panelist. Dr. James Jarvis, Director of Clinical Education, Senior Physician Executive and System Incident Command, Eastern Maine Medical Center. Dr. Leonard Kay, Director of UMaine Center on Aging, Professor of UMaine School of Social Work. Dr. Jordan Porter, Lecturer of UMaine School of Nursing, Student Health Coordinator of University of Maine Machias, and Family Nurse Practitioner, Down East Community Hospital. Dr. Noah Nesson, Innovation Advisor, Penobscot Community Healthcare, and formerly Chief Medical Officer, Penobscot Community Healthcare. Dr. Shannon Govin, Director of University of Maine Augusta School of Nursing. Jessica Taylor, Director of Care Management at St. Joseph Healthcare. And we'll begin with Dr. Jarvis. Dr. Jarvis, what is the importance of conducting research in rural communities, and what partnerships do you see developing in Maine to assist in such projects?
And thank you, Kelly, and thank you for inviting me to speak today. As a family physician, I see firsthand the need for us to do more research in our rural communities, especially from a clinical standpoint. Clinically speaking, rural populations are not the same as populations that are typically studied when we talk about clinical research. Clinical research tends to happen at academic medical centers and academic universities, many of which are housed in large urban areas. And rural populations just aren't exactly the same as that. They have less access to primary care. They have less access to tertiary care facilities. Oftentimes they're underprivileged in terms of finances, insurance coverage, and then just access, like I said, to basic health conditions. In addition to that, oftentimes lifestyles are not as healthy as they may be in some of our more urban centers, and therefore leads to diseases such as diabetes and hypertension or high blood pressure in higher numbers than we see in some other parts of our country. And so because of that, it's important to focus on those populations because they are different. But unfortunately, we have seen that that has not always happened because, again, access makes it more difficult and challenging. That's one of the great things about what we're talking about today is the partnerships that have developed here in the state of Maine, which actually really concentrate and reflect on our rural populations. Obviously, the university is based in a somewhat suburban rural combination. And then, of course, our health systems and our hospitals across the state are a blend of both suburban, urban, but mostly rural community hospitals. And it's important that we engage in them. And then engaging in other partnerships with other research entities in order to attract research to our particular areas.
Thank you. So you discussed some of the challenges that populations in rural areas face, and what are some challenges in conducting clinical research on rural populations?
Yeah, well, first and foremost is the population density. We look at the state of Maine having a population of 1.3 million, with somewhere around 700,000 of those people living in more rural communities. Many of them have access issues. If they were to participate in research, they may have to travel great distances just to get to a research center where they can participate in that. And that's challenging just for regular healthcare. If you add on that, hey, we'd like you to have some extra visits in order to participate in research, that becomes a challenge as well. Having access to academic sites. Here in the state of Maine, we only have one medical school. And so when we're talking about a focused academic center, that becomes difficult. Thankfully, the University of Maine fills in the gap with lots of other health professions, including your school and the School of Nursing, which participates in a lot of this kind of things. But we have no true academic medical centers. And that becomes a challenge for us when we have a hospital that's based purely for research and education while they care for patients. And so trying to see expansion in that is really something that here at Northern Light Health we're trying to do, and of course across the state of Maine. And then we also have a lack of providers who are interested in doing primary research. Most of our providers in the state of Maine, their job is to care for patients, which is really what we want providers to be doing. And that, as you know, can be a challenge, particularly after the pandemic, that's been challenging for us to get our patients in just for their normal needs. To take time aside from that work in order to do clinical research is sometimes daunting for providers who are not based at academic centers. And then we have a lack of awareness of certain businesses that rural health actually matters and that our rural population is a place for them to reach out to. We're seeing some changes in that. We see some drug companies that are very interested now in reaching out to rural populations because, frankly, most of America is rural. And so they're seeing that need and engaging a little bit more than they had in the past. And then lastly, we have an issue of either reluctance or resistance to participate in research that seems to be a little bit more involved in our rural populations versus populations in more urban centers. We saw that when we talked about vaccinations against COVID-19, that there was more hesitancy there to trust in the science and to participate in those kind of things until they've seen more progress occur and more research come out. Well, if we're talking about research, that's before that. And so overcoming some of those challenges are certainly something that we need to do.
So you discussed the difference between rural and urban populations and the need to really understand rural populations so that we can improve health outcomes. So how do we encourage more researchers and people in Maine communities to participate in research projects here in the state of Maine?
Yeah, well, first and foremost is definitely around education. I think we need to educate everyone that when we talk about research, that doesn't mean people are guinea pigs. Before we even talk, if we talk about just clinical trials for medications or drugs, they've gone through at least 2 other phases before they get introduced into clinical trials for populations. And so therefore safety has already been declared on that before we've kind of gone into that next phase. Incentivizing. We need to incentivize patients so that they are interested in participating in those. We need to incentivize providers so that providers themselves can take time away from their practice to be able to and be involved in research. And then I think we need to incentivize businesses so that they are interested in partnering with our centers of higher education as well as our healthcare needs. Collaboration, which again is I think one of the wonderful things that we'll talk about today, is how we are reaching out to one another and partnering with one another to expand upon that. We need to get our primary care providers educated in the importance of research, because we've found that when primary care providers reach out to their own patient population and say, hey, this is something that's in particular need for us, like a project that we're working on right now between Eastern Maine Medical Center and the University of Maine on trying to figure out if there's some predisposition for people to have chronic kidney disease and mapping their genetic components so that we can determine whether or not that predisposition exists. It was our primary care providers who have been getting us our patients who are now interested in being involved in that research. And then we need to look at the global community. Right now, I'm looking at 2 separate projects, one within Cerner, which is the health medical records that we use here at Eastern Maine, that have a population database that looks across all rural areas so that we can actually not just do research here in Maine, but we can also use the counterparts in North Dakota and Montana and other states that are mostly rural. And then similarly, the American Academy of Family Physicians is partnering with the NIH on a project called All of Us, which again is focusing in on rural populations and collecting enough data on those rural populations that we can then use those for research purposes. So that's just kind of a few things that we can think of that can overcome some of these challenges in this very important work of learning whether or not we have differences between our rural population and the urban centers where most research is conducted.
Great. Thank you so much, Dr. Jarvis.
My pleasure.
Our next panelist is Dr. Kay from the UMaine Center on Aging. Dr. Kay, the risk of elder social isolation and loneliness has risen significantly during the course of the pandemic, especially in rural communities. What additional research is needed on this topic?
Thank you, Kelly, and it's also great to be here today. Appreciate the opportunity. If it's not clear yet, let me attempt to make it crystal clear that we're in the midst of a pandemic, far less often discussed than COVID-19. And that is that of social isolation and loneliness, which exists across the ages, across lifespan, but perhaps is especially onerous and potentially lethal for older adults. 1 in 5 older adults over 50 are at risk of social isolation. You should know that subjective feelings of loneliness can increase your risk of death from 26% to 45%. And feelings of loneliness can increase your risk of functional decline by 59%. This has become a public health threat that is the equivalent, it's been said, of smoking 15 cigarettes a day. Increased isolation during COVID-19 has been accompanied by what is anticipated, in addition, to be rising older adult suicide rates, increased instances of elder abuse, neglect, and exploitation, increased visits to the ER and hospitalization, earlier onset of dementia, greater risk of heart disease, and delayed treatment generally for chronic physical and mental health conditions. This public health threat hits us economically in serious and significant ways as well. It's estimated that social isolation costs the Medicare system some $6.7 billion a year. That translates into 134 more Medicare dollars spent monthly for a socially isolated older adult, or $1,608 annually. That's more than is additionally spent for adults with high blood pressure, by the way. Research needs to show us the way in terms of what are the most effective and efficient strategies in which to, in effect, fix broken human connections such that people can thrive. These include understanding and teasing out the best home sharing models that make aging in one's home not only more affordable, but more socially satisfying. It includes how to design transportation services that are realistic to implement in rural communities. It includes the best ways to support retraining and retention of older workers, as well as ways in which to effectively increase strength, balance, and confidence, such that older adults are at lesser risk of falling and more willing to leave their houses. And I'll close by saying there's still no gold standard for identifying social isolation and loneliness in a population. And that is yet another contribution we're waiting for research to make.
Fascinating, thank you. The next question is, there is a movement emerging to advance age-friendly healthcare systems across the country. Are there areas of research that could especially inform our efforts in this area?
There are certainly, but let me make sure our audience appreciates what an age-friendly health system is. It's one in which every older adult's care is guided by an essential set of evidence-based practices. They are commonly called the 4 M's, in which attention is given to medicating individuals only when it is necessary, and using age-friendly medications that don't interfere or minimize interference with other facets of their lives. It includes preventing, identifying, treating, and managing depression, dementia, delirium across all settings of care. It is a style of practice that ensures that older adults are able to move safely every day in order to maintain their function. And perhaps most importantly, it speaks to what matters most by the older patient, knowing and aligning care with each older adult's specific health outcomes, goals, and care preferences, which include, but are not limited to, end-of-life care and preparing for one's own demise. So research, therefore, that determines whether there are particular elements of an age-friendly healthcare configuration that are especially critical and how they can best be delivered in rural settings is what's needed in my thinking, given the special challenges faced in delivering quality and accessible care in small towns and rural communities. And certainly developing effective education and training curricula, which are driven by research evidence for healthcare providers that are sensitive to the realities of rural life. And here I'm including sensitive to the fact of limited resources, service scarcity, cultural traditions, the availability of specialists in geriatrics, the geographic barriers and transportation challenges. All of these need to be factored in and embedded in our thinking around what age-friendly healthcare looks like. A lot of those, by the way, are what we call social determinants of care, because many would argue that the impact that the environment and conditions outside of the health center have a greater influence on one's health and well-being than not.
You mentioned the 4 M's, and one of the M's is what matters most. And we know that approximately 80 to 90% of adults indicate that they want to remain in their own homes until they die. What does research tell us about the feasibility and advisability of an aging in place philosophy, especially in our rural communities?
It's a great question, Kelly. And that the fact that we know there's 80 to 90% of folks exactly like you and I, who want to remain in their homes until their last breath is taken is because of sound research that is conducted periodically. And that, by the way, transcends age, race, income, and health status. We all want to remain in the familiar settings of our neighborhoods and communities. So the desire to remain at home is especially powerful, I'm going to argue, among rural dwelling older adults who value their independence most dearly. Research is needed, in my mind, to determine what the preferred combination or formula, if there is one, of home delivered services, informal supports, technology enhanced interventions, and self-care responsibilities and capacity are that enable an older adult to live safely while maximizing their health and well-being in their home. I would argue that additional research also remains needed that can help us determine that tipping point, which when reached, tells us that aging in place may create too much of an imbalance in terms of compromises that are being made to one's health, safety, physical, psychological, and economic well-being. At that point in time, aging in place may not be the proper terminology to use, but rather thinking about aging in the right place. Aging in the right place, because the right place may eventually become of paramount importance, such that a change in arrangements to a more supported and protective living environment is warranted. More research is definitely needed to help us make an informed decision in that respect.
Great, thank you so much.
Thank you.
Next up is Dr. Jordan Porter, representing UMaine School of Nursing, University of Maine, Machias, and Down East Community Hospital Family Practice. Dr. Porter, what is shame and how does shame impact rural health and well-being?
That's a big question. And a lot of times we don't like to talk about shame, but it's real. And it does show up in my patient exam rooms. And so I think we got to get clear about the definition of what shame is. And so shame is a universal human emotion. We all experience it at some point in our lives. We're going to come up against it. And it's that painful experience or belief about ourselves that we're inherently unworthy of love, belonging, and or connection. And so I think it's really important to distinguish between shame and guilt. Shame is I am bad, which is a focus on self. Whereas guilt is I did something bad, which is a focus on behavior, which is two totally different ways of thinking. It's the same thing of I am a failure versus I failed. I am a mistake versus I made a mistake. And so that's really important because you'll hear patients within the exam room making statements like, I feel like I'm such a bad mom. I'm such a bad dad, or I'm an addict. And there's such shame and stigma that's attached to that label, that identity of addict. And so there's other clinical clues as well. So I do universal depression, anxiety screenings. And so on the PHQ-9, which is a valid and reliable tool to measure depression, there's a question on there that says, over the past 2 weeks, have you been bothered by feeling bad about yourself, or that you are a failure, or have let yourself or family down? Okay. What is that really speaking to? It's a clue that, the patient, if they score high, a 3 out of 3 for that, specific question, it speaks to shame, really. And so I think we need to get real and honest about shame and what it does and how it impacts our health. And so we're finding with lots and lots of shame research, it's really a growing field, is that shame is highly correlated with addiction, depression, eating disorders, violence, and aggression. And I see that every single day. It's really the core, it's the heart, it's the underpinning of many of the disease processes that we see. And so I think it's important because when our patients are chronically living in this place of shame, it's debilitating, it's crippling. And so developing resilience around the shame, it's not that we're not supposed to experience shame. No, it's a universal human emotion. But when we can name it, there's power in naming it and developing resilience around it. That's the key. And so one of the things I always try to remember is one of the greatest triggers of shame is an unwanted identity. Okay, so think that term addict. Think other things I see, I would say the identity of fat, obesity, right? I am fat versus I have fat. Okay, I am fat is a shame statement. I have fat is a guilt statement, right? There's a difference. And or think poor, poverty, right? I am poor. Oftentimes is a shame gremlin for those in rural communities. Stupid, okay? We've been labeled stupid inside the four walls of a classroom, or maybe inside our family home. And so we internalize that, and that can be our shame gremlin. So it's also important to point that there's a relationship between shame and scarcity as well. So sometimes patients will say, I feel like I'm never good enough. I'm never doing enough. And so when we think of rural communities, there are often scarce resources and scarce opportunities, scarce relationships, meaningful, healthy relationships. And so, that matters. And we have a huge crisis in terms of, safe, stable housing here in Washington County, Maine. And we have a lot of work to do. Food insecurity, another one. And poverty, absolutely. We're one of the more impoverished counties across the state. And so this is why this matters. And this really goes to the core, the heart of the issues that we see here. And we would be amiss to not talk about it. And is it hard? Is it uncomfortable? Is it tough? Yeah, it really is. But it's also some of the bravest work we can do, especially as clinicians. And so that's why I really try to center, personhood, dignity, worthiness, inclusion, and belonging of every single patient that I encounter, because those are non-negotiables in my exam room. So, and those are often the antidotes to shame.
Interesting. So you mentioned shame, and we've recently paid more attention to the term adverse childhood experiences and how increased scores of adverse childhood experiences negatively affect health. So in your practice, in the context of adverse childhood experiences and shame, what evidence-based strategies do you employ as a family nurse practitioner to build and nurture psychological safety and trust among rural patients in Washington County?
Yes. So I think it always starts with self-awareness on the clinician's part. We got to be self-aware. That's where it starts. We got to own our biases before they own us. We got to own our words and maybe where we failed or made mistakes in terms of our relationships with our patients. We've got to own it. And it's this, if we don't own our words, our emotions, and our own behaviors, they end up owning us personally and professionally. Like, we can't connect with patients and create psychological safety until we connect with ourselves as clinicians first. That's where it starts. That's the birthplace. And I think it's really important to make an active commitment to creating trauma-informed cultures that value personhood, belonging, and inclusion. Like, these are non-negotiables. I think being able to speak them out with our patients on that first day that they establish care with us, naming the value of belonging, that's what we live into. Like, this is something that I often say with my patients on that first visit. Like, this exam room belongs to you just as much as it belongs to me, if not more. And that helps create that psychological safety that they need. The idea that you can be here, you can be you, you can belong here as you are, exactly as you are, even the messy parts, even the hard, tough parts, they belong. And that in itself, it almost like dismantles that power over structure that is so prevalent oftentimes within the hierarchy of the healthcare system. And so being able to dismantle the power over structures and give power to and power with these patients from rural areas that are often marginalized and oppressed, that's where it starts. And then I think, active listening, having an empathic ear is critical to connecting with these populations and stewarding their stories. The idea that we value and we care for and we honor their stories like they're our own stories. There's power in that. And it's been amazing. Some of the most meaningful patient interactions that I've had were born out of vulnerability. They were born out of vulnerability. They were born when I was vulnerable and open. They were vulnerable and open. And at the end of the day, we want our patients to be honest and feel safe and secure within the exam room so that we can deliver the best care to them, that we possibly can. If we can have all the knowledge in the world, but if we don't know how to have meaningful connection with our patients, it's meaningless. It's where it starts.
Great. Thank you so much. And next is Dr. Nesson, representing Penobscot Community Healthcare. Dr. Nesson, we were just speaking about the importance of connection and primary care. What are barriers to access to primary care, especially in rural areas?
I think the primary barrier is capacity, and I'll speak a little bit more about that. There are some other obvious barriers. Transportation is a barrier in rural areas for a lot of people, and Len has spoken about some of those issues. Communication is a problem in rural areas. The kind of things we do to enhance communication, like the use of a patient portal, if you don't have reliably good Wi-Fi, really hard to take advantage of that, or something like telehealth. And then traditional settings and traditional hours are barriers in rural areas where people either have mobility issues, or they got to work, or they got to take care of their family, and coming during the hours in which we're traditionally open to see patients in primary care are problems. But the biggest area is capacity. We know that there's a dwindling population of primary care providers, doctors, nurse practitioners, and physician assistants in rural areas. That's true in rural Maine. We know critical access hospitals are threatened all across the country. Over 100 have closed since 2010. With 2 of them in Maine declared bankruptcy in the last several years. They seem to be doing better now, thankfully, but that's a real threat to a rural community. And we know it's hard to attract and retain primary care providers, especially primary care physicians, in rural areas, and we've not developed other models of care that allow people to reliably access primary care in lieu of having a robust population of primary care providers. And the barriers to getting primary care providers into rural areas and retaining them are fundamentally, it's that primary care is undervalued by the system. A ton of money is spent on healthcare in the US every year, but not enough of that spend is in primary care. And so in order to be sustainable, you have to do a high volume of work. And doing a high volume of work means you can't go and make a house call, because that's not financially efficient. Or you can't spend 45 minutes or an hour talking with someone who's suffered a significant trauma or who has a history of trauma to understand who they are, because that's not financially efficient. In addition to that, we've made transcriptionists out of our providers. So it's as if we went into a court and told a lawyer, you also need to be the court reporter. Electronic health records are very important advances in healthcare data and healthcare information sharing, et cetera. But making the doctor, nurse practitioner, PA, the transcriptionist during the visit robs us of our face-to-face time with our patients to have the kind of conversations that Jordan was so beautifully describing a little bit ago, and we've been slow to compensate for that. I say it's the 4 T's of burnout, which is time pressure, which I've just described. The fact that what we've done has become more and more transactional rather than relational. And the relational aspect of our work is what's most important to our patients, but it's also what's most important to us. And I think the loss of that relational aspect is the most significant cause of burnout among primary care providers. And too much to know. The information explosion means that compared to when I started a private practice in Mattawankeg, Maine 36 years ago to now, there's infinitely more information to know to take care of my patients. And we've been very slow to use things like artificial intelligence to help us manage that information overload. And we've continued to rely on a very traditional approach of good intention and strong memory skills. And easy access to apps on our phones, but that's not. It still has to be triggered by the proper thought process to get to which app do I need for this patient, and we could take much more advantage of things like artificial intelligence to help to address that as well.
Interesting. And you mentioned primary care and some of the challenge with accessing primary care. And some people think, why do I need a primary care provider? I could just, I can go to the ER if I am sick, or I could go to walk-in care if I have a problem. And why exactly is primary care so important?
I think it boils down to the relational aspect of primary care, that if we're able to do it and do it well, that relationship between a primary care provider and their patient is so important to both of them. That it contributes to well-being. We know from studies, for instance, that if you add 10 primary care physicians or providers to a population of 100,000 people, the average life expectancy goes up like 55 days or 51 days, something like that. So there's data to show that access to primary care improves outcomes, but more importantly, that trusting, caring relationship allows you to have the kind of conversations, for instance, with our older folks in Maine, the 4 M's, the things that Len talked about. You have to have relationship to be able to get that information in a meaningful way from people, and to process it and to serve them in the way they deserve to be served. And in order to make them the center of the care, the patient-centered approach, the patient is the key member of the primary care team, but they can't be a member of a team that's a transactional model. It really has to be a relational model. So I think that's really what's critically important about primary care. If you think about the major challenges we've faced just in the last 10 years, the opioid epidemic, that's only going to be solved by being able to provide, to do preventive work in addressing trauma in rural areas, for instance, especially, but also being able to offer destigmatized approach to care and treatment for something like a use disorder, whatever the substance is, or treating other diseases of despair like depression and the impact of trauma and shame, for instance. All of that matters. And in the course of the pandemic, what we've learned is that the only thing that sort of stood the test of time through the pandemic is the trusting relationship, established relationship with a primary care provider to help people with their decision-making process. So I think it's just critical. And we know that when in a rural community, when they lose access to primary care, that community and individuals within the community express the loss, the suffering that results from that.
And you mentioned the pandemic and some of the trusting relationships that got us through, and we certainly saw that even across health organizations and our existing relationships and how we were able to care for our community. So what lessons have we learned throughout the pandemic about our healthcare delivery system and public health, and what can we use moving forward as some of the areas that worked for us during the pandemic and kind of continue in that area to enhance primary care?
Well, very quickly, I would say, we've learned a lot of really good things like how to use telehealth. And we've been discussing that at PCHC, for instance. For chronic disease management, we've decided there's virtually no visit that can't be done by telehealth. And then, of course, if it's determined through that telehealth appointment that an in-person visit is needed, we can do that. But there's lots we can do by telehealth if people have access to a screen and Wi-Fi that allows them to connect. We've learned the importance of good information, consistent messaging in the context of the pandemic. And we need to build a base of support for public health, because public health is a concept. It doesn't have any meaning to you or me as an individual seeking healthcare, but we have to help people understand the concept of public health. And we can also do that through our primary care relationships with people, so that they understand that there are times when the community has to work and act together in the interests of everybody. So I think those are two really critical lessons that we can take from the pandemic.
Agreed. Thank you so much.
It's a pleasure.
Next up, Jessica Taylor, registered nurse representing St. Joseph Healthcare. And Jessica, we've discussed the importance of social detriments of health and of course the effects of the pandemic on our communities. So in your role, how has the pandemic highlighted the vulnerability of those in our community struggling with social determinants of health?
Yes, and thank you very much for having me here today. I've had the opportunity now sitting here for a few minutes to listen to the wonderful panelists that spoke before me, and already I'm able to see some patterns that are emerging, some common themes where we're looking at the Maine and being a rural state, and all of those themes are all related to social determinants of health. For instance, Dr. Jarvis talking about access to health care, Dr. Porter about housing, and Dr. Nesson about capacity, through the lens of having providers that are available. Social determinants of health are any condition that exists in the environment where people live, learn, work, or play that impact their quality of life and their access to health and functioning, within the community. And some of the biggest social determinants of health that folks struggle with here in Maine and other rural communities are safe housing, transportation, food insecurity is a very big barrier here in the state of Maine, and literacy is also something that impacts an individual's quality of life and their access to wellness. So all of those things, if a person doesn't have support with that, or if we're not viewing the patient holistically through that lens, can have a real impact, on the patient's quality of life. So for instance, I think about during the pandemic, we got a lesson in social determinants of health overnight. And, I think about, elderly patients. I work here also out in primary care and in the internal medicine office. And here at St. Joe's, the minute that the pandemic hit, we started reaching out to anyone in the high-risk category, the care managers did, to make sure that they were okay. We didn't even know what we were dealing with initially, but to make sure that they were okay, did they have the support, did they have what they need? And we immediately saw one of the biggest social determinants of health, access to nutritious food, bubble up to the front. For instance, again, our elderly patients that we were outreaching may have lost a caregiver because the caregiver was worried about coming out, or their services in their home were put on pause because of the pandemic. So they may have not had access to getting out to purchase food, or go to medical appointments or pick up prescriptions, or the transportation that they might have been utilizing was no longer available because it was on pause because of the pandemic as well. Low literacy for a lot of folks here in Maine is a barrier. The average reading level in the state of Maine, as many folks know, is about a 6th grade reading level. So that can have a huge impact, especially when folks quickly have to navigate resources or switch over to online education and learning. So again, all of these things, when we're looking at the most vulnerable in our population, you know, this can really highlight the things that they're struggling with. And we did see this so much, you know, during the pandemic.
You know, we've talked about patients' resilience and vulnerability and adverse childhood experiences, and we've also talked about our healthcare system and rurality. What are some of the takeaways or lessons that we've learned from this pandemic for building our community's resilience?
Yes, thank you. Great question, Kelly. You know, community resilience is the sustainability of a community to rally or rise above adversity or something happening just like the pandemic. It's the ability of the community to utilize the resources that they have available to help to support the most vulnerable in the community. And one of the takeaways or lessons that we saw during the pandemic was the true benefit of collaboration. You know, no man or woman is an island, and definitely saw the impact of that, and very proud that we did that. People came together very quickly to ensure that there were ways that we could help to mitigate risks in our communities. We all had a purpose, common goal. We were not working in silos any longer, and we haven't been ever since the pandemic began. You know, the collaborations in the communities that during the pandemic are too numerous to mention, but I think that, you know, again, looking at the community through the lens of social determinants of health and the community's ability to leverage resources to support the most vulnerable in our community, the value and continued value of collaboration and sharing of resources really truly is something that can help any community be sustainable and build resiliency.
I cannot agree with you more. I've never been more proud to live in this community as I have over the past 2 years. It's been remarkable. As a nurse working with some of the most vulnerable patients in our community, what are some resources you feel we need to cultivate, develop, expand, improve upon, and why?
I think that, you know, again, looking at our communities and the vulnerability during the pandemic, I think that there's a lot of lessons learned, and I think that one of the things that we really need to start leveraging and cultivating, if we want to look at improving the the impact and reducing social determinants of health in our communities, is food insecurity. You know, first and foremost, we need to definitely take a proactive look at this and not a reactive look, you know, for when someone shows up on our doorstep in our health system and they're struggling with this. You know, if you look at Maslow's hierarchy of need, food, right there on the foundation, it's right on the bottom. It's the first step that needs to be addressed. You know, so when we're looking at population health, you know, as a whole, and we're considering chronic disease and those other things that folks are struggling with, you know, we really have to start first and foremost to look at food insecurity, because food insecurity doesn't just mean that there's no food in the cupboard. When you open the cupboard, it might mean that people are stretching $1 because they don't have enough money to buy the healthy food that they need, or they may have plenty of money but don't have access to that food. For instance, I think of the elderly in our community. You know, Dr. K spoke about isolation, and a lot of our elderly in our community might have money, but they have no way to get to that healthy food. And so, you know, again, I think that is something that is a lesson learned that we need to bring forward and cultivate more resources for that. Not just in the form of pantries. Pantries are fantastic, but they're open one day a week. And it might be just in an urban area. And so if someone has transportation issues, it would be very difficult, you know, to access that food that might be there. So I think that, you know, we don't have to reinvent the wheel. There are many places that we can utilize that can be a great resource to put a food box for a community that might be struggling. It could be a town office, a church, schools, local stores, and partnering with those businesses to ask if we can, you know, put a food box in there or start a small pantry. You know, so again, I think that, you know, food insecurity is not just a community issue, but it's a statewide issue. It's a healthcare issue. It's an education issue. It impacts a person's ability, you know, to grow and achieve wellness and even function. So I would, again, invite anyone that's looking at population health the community's sustainability and vulnerability and resilience to start with that bottom level. First things first, Maslow's hierarchy needs, or maybe instead of first things first, food things first.
Great. Thank you so much, Jessica.
You're
And
welcome.
then last but not least, we're going to shift gears a little bit from healthcare and discuss our health professions workforce and how we educate them. Dr. Shannon Govan is the Director of Nursing at the University of Maine, Augusta. And we're going to discuss nursing education and rural delivery. So we have University of Maine, Augusta has several distance sites serviced by the nursing program. How do you meet student learning needs in those rural areas? And how does providing education in rural areas support workforce development in nursing?
Thank you, Kelly. So UMA is very unique in that we've actually been engaged in distance learning education models for decades. We have 10 physical locations across the state, all the way from Millinocket to the Western Mountains in Rumford, down to Saco. So we really do cover the full state as far as providing access to students. Specific to nursing, we offer the BSN program through a hybrid model where we have both live courses that we offer on the Augusta campus for those students that live in that region, but we also offer all of our theory courses in a section that is synchronous Zoom. So what that means is it's a live class where they're engaging with their professors at a set time, but they're able to do it either from the center in their region, if that's what they choose, or from their homes. And then we serve the students in four different centers that UMA has. We have the Ellsworth Center, the Rockland Center, the Brunswick Center, and the Rumford Center. And we also have a collaborative partnership with the University of Maine at Farmington, where the students are able to participate in live labs and clinicals right in the communities that they live. And by providing these place-bound students this opportunity, we're really providing workforce development right in those communities because they're place-bound already. They're going to live there, they're going to work in those communities. So by providing them this hybrid model of nursing education, we serve not only the students, but the communities in which they live.
And Shannon, we know that we're in a critical nurse faculty shortage, and sometimes I don't think the public truly understands the crisis we're facing in nursing education. We turn away hundreds of students in the state of Maine each year due to the faculty shortage that we're all experiencing. So with this shortage, how are you able to continue to grow the distance education model you offer at University of Maine, Augusta?
So we came together with some of the areas that had the greatest need and said, we need your help. So we partnered with some of our healthcare facilities, specifically Maine General, and then Coastal Health is providing a nurse clinician that's at the bedside that's qualified to be faculty, but they're keeping them employed by their facility and just releasing them to provide clinical education to our students. It's really a win-win-win because it helps the nurses to kind of spread their wings a little bit. It helps to prevent burnout. It's allowing them to really meet some of the future nurses they're going to work alongside and really tailor them to kind of fit into the cultures of the organizations in which they're having clinical. And we're able to increase our enrollments without having to hire additional faculty because they're already employed by the facilities.
Yeah, that's great. And we're looking to expand that model into other parts of the state to help all of us with this faculty shortage we're experiencing. So at UMaine Nursing, we have students in person, 50, 70 students in a classroom our population tends to enjoy dorm living, fraternities, sororities, sports, etc. They're typically students coming right out of high school. How do you see your program as unique to other programs in our University of Maine system? And is your model sustainable?
That's a great question. So UMA is unique in several different aspects, really. It's the population that we serve. Our average student is 32. it's a second career, or it's a first time family member ever attending college. We are primarily a commuter college, though we do have a couple of dorms. We do have live classes on the Augusta campus for those students that want that traditional experience. And then we have that other offering where students that live in rural communities and can't, uproot their lives and go to a college campus, whether it's because they can't afford it or they have families that they're tending to, that we are able to provide them that same high level quality education at those distant sites. We were able to secure some of the higher education emergency relief funding to outfit each of our distant sites with high fidelity simulation equipment so that the labs that they're engaging in are the same experience that the labs that the students on the Augusta campus are engaging in. And our curriculum is endorsed by the Holistic Nurse Association, which means that at the time of graduation, once they secure licensure, our students are eligible to sit for the Holistic Nurse certification. We were created as a distance model, so therefore we're able to really meet the needs of those students that are in our most rural parts of the state and are place-bound.
Fantastic. And what other additional proposals are in development to meet place-bound students across the state?
Well, recognizing that the nursing faculty shortage is not going to go away, we have partnered across the system, Kelly and Fort Kent, Aaron Susi and Bren Peterson and I, to work on a couple of funding requests to really partner with our healthcare facilities so that we can identify ways that they can support the need for us to increase enrollments, because we can't do it alone. And we recognize that there is a high level of burnout, and there's research that supports that clinicians that have the opportunity to participate in other activities while still taking care of their patients at the bedside helps to reduce burnout by making them feel more fulfilled. It's their way of being able to give back to the nursing community. So that's one of the ways that we are partnering across the state. And we're just looking for ways that we can collaborate, recognizing that each one of our programs has its own unique strengths, and really empowering one another to kind of become the leader in that area so that we can support each other and really increase enrollments across the system.
Exactly. Well said. And we recently, if you want to just touch base on the bus that we just were awarded, it's going to be really exciting.
Yeah, sure. So we were granted $1 million grant to have a mobile sim lab, which is super exciting. It's the first of its kind in the state of Maine, and it will be a very large camper bus that is kind of outfitted as a simulation lab. And the focus that we kind of submitted was for the specialty areas, because we're so limited across the state of Maine with clinical sites for obstetrics and pediatrics, that this van will have a birthing simulator, a pediatric simulator, and an infant simulator so that we can service all of the campuses within the system and provide students the opportunity to engage in some of those clinical scenarios that will help to prepare them for employment once they graduate.
And Shannon and I will be getting our CDL license in the meantime, so we can drive this thing around.
Right.
Thank you so much. And at this time, we're going to open up the Q&A for any of our attendees. If you want to ask questions of our panelists, you can enter them in the Q&A box. And while we're waiting, do any of the panelists have questions of each other? Dr. Nesson?
I have a question for Jim, because he's done a remarkable job in the pandemic response for the Northern Light system and really across the state. And in doing that, did a lot of communicating around a very controversial topic, which is the pandemic and things like immunizations and masks. And I'm interested in I saw him do that in big settings and in media and in little school board meetings, and I wonder what critical lessons, Jim, you learned from those conversations.
It's a great question, and one I appreciate the compliment, but it was definitely not me. It was definitely a collaboration across our entire community, and it's one of the things I'm most proud of in my career. Wish I never had to do it, but I think one is that fear is an incredible motivator. It motivated a lot of people to step up and stand up and get their vaccinations and do the things that are right. It also led a lot of people to question a lot of what was going on during the time. And I think, when I would sit down one-on-one with people who were hesitant about whether they wanted to get vaccinated or whether their kids should be masked in schools, often it was just a fear factor. It is a fear of unknown. I don't know what is behind the pressure to do these kind of things, or I don't know what it means to me personally. And I think, that's where being a good healthcare clinician makes a big difference. It's listening to your patient population. And in this case, my patient population happened to be the greater community of Maine, and hearing what those things were, and then pointing out what we did know, and more importantly, what we didn't know. And I think that's where some people got a lot of fear, is that they focused in on the limited knowledge that we had at the very beginning of the pandemic versus the amount of knowledge we gained through the last 24 months. We're in a much different place now, and I think educating people about that we are in a different place. I continue to hear pundits talk about statements made to the media way back in March of 2020. This is not March of 2020. We know a whole lot more now. And I think just kind of going through those things. So really, it's listening, addressing people's fears and concerns, and then hearing back from them after you've addressed them.
Thank you. We have a question, Len, if you'd be willing to share your data on isolation and comorbidity. And I think we're going to get a list of the attendees, so I don't see that as being an issue for the person who asked that question. And then there's another question about the volume of patients. And I think this is actually a very good question. And I perhaps Jordan, Shannon, and Dr. Nesson could answer this question, weigh in on this question, but how does the volume of patients that providers and nurses care for affect our ability to educate future healthcare professionals? Start with Shannon.
Yeah, that's a great question. I think that we've been very fortunate in the state of Maine in comparison to some of the other states in that our clinical partners really still allowed the majority of the students to continue with their practicums and with their clinical education. We have had to be very creative, especially in the areas where there's the most vulnerable populations, like mental health and pediatrics. I think those affected our clinical rotations the most, but we have found ways to provide our students with similar clinical experiences in different areas. We weren't able to use the school nurse like we have been able to because their workload, more than tripled, and just not being able to allow them into schools, we had to identify other ways to provide them with those types of experience. So it's been challenging. It's allowed us to be creative. It's allowed us to consider other ways to really meet the student learning needs. But I think that, again, thank you to all of our healthcare partners that really supported us through the pandemic in recognizing that these students are going to take care of these patients. So they needed the opportunity to still come and do that.
Yeah, great. Dr. Nasson, do you want to weigh in on that? Because I know when we try to educate nurse practitioners, the panel size is often a challenge.
Yeah, I think there's an obvious impact, which is when people are really busy, even if you take students, that time pressure that I always talk about has an impact on the quality of the experience that the student has there. You'd like, to really have the student engage with people, do their own thinking, and then go through it again with them. But often the time pressure doesn't allow for that. Moreover, I think a more subtle and pernicious effect is that's a premium is set on, how quickly can you document this visit? How efficiently can you run your workflow so that you can get through this too tight schedule and get home at even the semblance of a reasonable hour? And those become the things that the students see as valued as important. And that's to the detriment of things like, how do you hear somebody's story? How do you really understand the story? What's the role of your own empathy in the care for these folks, and in your decision making? And then practically, what tools are available to you, and what other resources, human and otherwise, or other team members can help you buy back some of that time to strengthen your relationship with your patients. That's the kind of education that I think we need to be doing more and more of, in order to serve people well in any setting, but most especially in rural settings.
Yeah, great. Thank you. Okay, the next question, let's start with Dr. Porter, since you work in Machias. What additional resources do you think are needed for clinicians in rural areas to sustain their work as healthcare providers in these parts of Maine?
I think one of the greatest investments here in Down East Maine would be building the social workforce. I am a huge fan of social work, and I always say to people, social workers, I call them social warriors, because they're amazing. Truly underestimated, and they bring so much expertise. And to be able to see from that view of the social determinants of health and how that impacts our rural patients, I'd say that would be the best and greatest investment to sustain this important work for our rural health communities.
Great, thank you. And then there was another question that we had in the chat, and we'll start with Dr. K. What opportunities within the UMaine system do we have to prioritize research and education in rural communities in partnerships with UMaine Augusta and UMaine Machias?
Terrific question, Kelly. First of all, I think I can respond to that by first announcing that I'm pretty proud to say that the University of Maine has joined the global network of some 90 higher education institutions across the globe, as encouraging, promoting a wide range of aging-related activities. As a member of the global network, I think the charge of the University of Maine is to respond to that question in a variety of ways, to work with other campuses of the system, in advancing age-friendly opportunities for older adults, in education, in recreation, in enriching their lives culturally, but also giving them a voice, allowing them to involve themselves in decision-making, and participating in research. Much of our research across the system has elements of a participatory nature. And I think the opportunity has not been taken advantage of involving older adults in our research enterprise. So, and I'll say finally that the Center on Aging is committed to working with any and all organizations, not only within the system, but around the state, to creatively think about ways in which aging can be advanced educationally, via research and evaluation, and also in the delivery of effective community services. So I encourage whoever asked that question and others to contact the Center on Aging, and we'll do whatever is in our power to help you move forward on the aging front.
And he means it. So send him an email. And Dr. Jarvis, the next question, there's a question about, is there an infrastructure for Maine hospitals to collaborate with universities? And I know at UMaine School of Nursing, we do have a joint appointment in nursing research between UMaine School of Nursing and Eastern Maine Medical Center, but I also know there's other efforts underway. So maybe you could speak to that from Northern Light Health perspective.
Sure. So, we're blessed in our state to have two very large tertiary care facilities. One is Maine Medical Center in Portland, and the other being Eastern Maine Medical Center here in Bangor. Both of them have the infrastructure to do research. So I'm very biased in that, as the Clinical Research Center at Eastern Maine Medical Center reports directly to me. And I know some of my staff are actually on as guests on this call. We're proud of the work that we do. And so Eastern Maine Medical Center actually has 3 separate research centers, one at the Lafayette Family Cancer Institute, one at our cardiology program, and then the Clinical Research Center, which really covers the breadth of medicine. And so that infrastructure is there. What we need to do is expand upon that, put the resources in place so that we can continue to do those things. In addition, our host today, the Institute of Medicine at the University of Maine, has really worked hard. We started really at the beginning of the pandemic, and we have worked hard throughout the pandemic to continue to build collaborations between not just the university, but with other partners around the state. So Jackson Labs, MDI Labs, the Rue Institute, and then bringing together the 2 largest health systems in the state, as well as the University of New England. And so we are really partnering here. And what I would like to see happen, and what I know that's what the Institute of Medicine's mission is to see that we don't just think of us as independent groups, but we look at the state of Maine as the academic center for healthcare for the country. It's a great place for people to live, learn, and work and provide research that will not just have long-lasting effect for Mainers, but I think could have long-lasting effects for everybody who lives in rural communities.
Great, thank you. And there's a question that I love personally about, is there a plan to increase the nursing faculty? And part of that plan, honestly, is to educate more of the public about the critical crisis that we face in nursing education, because there's often, just such a focus on the workforce shortage of nurses. And then the immediate reaction is just increase enrollments in nursing programs, but truly without taking one step back and thinking through the faculty shortage, we really cannot continue to increase enrollments, or our whole system will collapse. And we definitely do have a plan, and we recently submitted a $10 million grant to address many parts of the nursing shortage, in large part the nursing faculty shortage, which involves partnerships to expand on what Dr. Jarvis said, and to completely agree with him. It involves all of our healthcare partners across the entire state of Maine, and working together collaboratively in academic practice partnerships to build faculty right at point of care, so that they don't have to leave their clinical position to work in education. And we would also then educate them simultaneously to increase our increase the education levels of our nursing workforce. So we're really excited, and fingers crossed that grant gets funded, but we won't give up in the meantime. Because this is a daily conversation that we have in the nursing education world. So I appreciate whoever asked that question. Okay, and then we have another question about, are there collaborative research projects planned that could include other schools such as psychology, social work, occupational therapy, and physical therapy? And I can speak to this a little bit, but Dr. Jarvis and Dr. Kay, do you want to also address this? We'll start with Jarvis.
Yeah, we would welcome such things. So we do have some things that are ongoing now, but clearly, when we talk about clinical research, when we're from a hospital standpoint, we're talking about the breadth and depth of medicine, and that includes all healthcare professionals. There's plenty out there for things to be done, and we would welcome those conversations.
And let me add that the Institute of Medicine is laser focused on providing what it takes to expand research across professions and disciplines. We really want to make that crystal clear that pilot funds for University of Maine researchers in a variety of departments, including psychology and social work and nutrition and nursing, communication sciences and disorders, and I could go on, but all are invited with open arms to engage in research that will has the capacity to improve quality of life and safety and well-being among older adults and their caregivers across the state. And for those disciplines and professions to do that research, you can bet they need to partner with healthcare institutions across the state. And they need to partner with other higher education institutes outside the system. As an example, the University of Maine is partnering with the University of New England at this very moment in the delivery of geriatrics workforce enhancement programming. We call that GWEP, GWEP. So we are working hand in hand, a private university and a public university to enrich, expand the workforce that will be serving older adults in the healthcare sector, at the same time that we're retooling and training practitioners on the ground in healthcare institutions in the community.
And Jessica, as a care manager, do you want to speak to this question just about potential for collaborative research and with the interprofessional team? Oh, I think we lost her. You're mute. You're muted. No, still muted. We were bound to have a little technical glitch. At least
Can you
one.
hear me now?
There we go.
Wonderful. So again, regarding collaborations, regarding research and education with nursing and healthcare opportunities, definitely, you know, as others have mentioned, there's a need there, you know, to strengthen the workforce from the nursing perspective, allow opportunities for nurses to seek experience in multiple settings. And, you know, during the pandemic, there were challenges there for sure. And I think that people were, you know, wonderful at allowing creative thinking and outside the box so that folks could get their experiences. And I think it's time now to look at opportunities again for, you know, to allow for research and to have nurses kind of at the forefront of that and looking at, you know, especially in a rural state like Maine, and there are definite barriers to educational sites, but ways to grow that and resources to help to sustain and support that.
Great. And is there anyone else I missed that might want to respond to this question? Okay, I'll just add that we were recently funded for a research project to address burnout and resilience among nursing students, faculty, and staff, and that's in collaboration with the Department of Psychology, the School of Food Science and Nutrition, and the New Balance Recreation Center. And we are implementing multiple interventions across our program designed to reduce stress and increase resilience of our population, including mindfulness-based stress reduction, physical fitness, mindful eating, and a whole range of fitness interventions, including Fitbits for All. So we are part of a national model, and we're really hopeful that the interventions work and that we can address burnout, because it's definitely a crisis across the health professions, especially in nursing. All right. Any other questions? Did I miss any? They're kind of coming from two angles. Thank you, Cheryl. That's a great comment to end the session. All right, if there are no other questions, we can wrap up. But if anyone's has a question they're nervous to ask, no one else sees them except for me. So you can also ask them anonymously, so don't be afraid. Oops, someone's asking. Someone's sending me a link. All right. I thank you all so much for joining us today, and thank you to our panelists for your expertise and just for an exciting conversation about rural health in Maine and how we all working together in the areas of research and healthcare and education. Thank you so much, and have a great rest of your day.
Thank you.
Great, thank you.